Good afternoon, everybody, and thank you for joining us for the August Choosing Wisely Learning Network webinar. This month, we'll be discussing a framework for engaging providers to reduce overuse. We're hoping that this will be a very interactive session, so we encourage your participation in polls in the chat box and when we open the lines. Before we begin, I want us to cover a few logistics. This meeting will be recorded and shared. While our presenter is speaking, we will have the lines muted to reduce unnecessary noise, and we will unmute during all of the polls, and the lines will remain unmuted after Dr. Parchman has presented the framework and use case. We are hoping to do a number of polls today, and I have to be the presenter to be able to do the polls, so I'm going to take that away from you, Michael, and open up our first poll just to get everybody used to how to do it. I want to point you to the lower right-hand corner where the poll is, and I also want to just let you know that you need to click on the box, not the lettering, because if you click on the text, it'll just say that you have no answer. But if you click on the box, it does let us know who's in the room, and I can see that several of you are doing it correctly. So I appreciate that. And while we see who's participating today, I'm going to introduce our speaker. So I'd like to introduce Michael Parchman. He's a senior investigator and nationally recognized scholar in chronic illness care, who's been a director of Kaiser Permanente Washington Health Research Institute's MacColl Center for Healthcare Innovation since 2010. A family practitioner and health services researcher, Dr. Parchman previously served as the director of the Agency for Healthcare Research and Quality's Practice-Based Research Network Initiative and senior advisor for primary care. Dr. Parchman's research focuses on using complexity science to explore how diverse healthcare teams can work together to achieve high-quality care. As part of this aim, he leads the Robert Wood Johnson Foundation-funded project, Taking Action on Overuse, focused on engaging primary care teams to de-implement needless tests and treatment, doing less overused, low-value care that might harm patients. So I'm just going to switch this presenter back to him so that we can see the slides and turn it over to Dr. Parchman.
Do we get to see poll results?
And while we change that, I am going to close the poll and show the results. Do you have you do, you don't have the poll yet. Oh, I think I have to close the poll first and show the poll results. There you go. So you should be able to see the results. And now I can actually give you the presenter.
Great. Fantastic. Okay. Well, thank you, Kelly. Can you hear me?
Yep.
Oh, good. All right. Well, thank you. And I want to thank everybody for joining me today. I want to tell you a story about our journey over the last 3 years in working with the Robert Johnson Foundation on this issue of how do you get providers to engage on taking action around overused services. So this journey really began 3 years ago for us when the Robert Johnson Foundation approached us with this challenge, and they kind of threw down the gauntlet in front of us and said, okay, you guys figure this one out. And being the fools that we are, we took up the challenge to try to figure this out. And this is the issue. The issue is that over and over again, we know that in soccer, when there's a penalty kick, the best possible thing a goalkeeper can do is stand in the center of the goal and not dive to one side. But surprisingly, they rarely do this. And so one explanation for this is that, standing there and doing nothing doesn't look too good. And I can tell you, as a family physician, practicing family physician, and a clinician of now 30 years, it really does feel bad when you're standing in the center of the goal, when you're in a patient bedside in the hospital or an exam room, and not offering to do something. And that's the challenge we're up against when it comes to choosing wisely and low-value care. I didn't go into medicine to tell patients that there's really nothing I have to offer or nothing I can do for them. And increasingly, we're realizing that perhaps is one of the most effective strategies, the watchful waiting kind of strategy. This is the article that came out in JAMA this year about choosing wisely, a work in progress, in which the authors commented on, the progress of choosing wisely really over the next 5 years is going to be measured by the degree to which we can get physicians to engage in this work over time. So for us, engagement is the missing piece of the puzzle. We know where the waste is. We know where overuse happens. We know how often it happens. We know how much variation occurs. And we know the consequences of overuse of low-value care. So why is it so difficult? Why is it so difficult for us to engage in this? And so what I'm going to do today is walk you through kind of the framework that we developed around our learnings from exemplar organizations that have tackled this work, a little bit about our partnership with 3 other healthcare organizations who use the framework in their own work to do some work around overuse in their setting, and then some of the high-level findings that came out of those partnerships about engaging providers in addressing overuse. So the first thing we did 3 years ago is say, well, what do we know about engaging providers, teams, and patients in overuse? We had 22 conversations with leading exemplar organizations across the country who had done work in this area. We had a national advisory committee of experts who knew and had experience with this area. We actually did 4 site visits to 4 of these 22 exemplar organizations, and we did not just a review of the peer-reviewed literature, but outside that into social science literature and other areas of literature around sociology, behavioral economics, and behavior change to figure this out. And what we ended up with is this framework, and I apologize for the small type on this, but we're going to walk through each component of this framework, so don't squeeze your eyeballs too hard trying to make sense out of the small type on this. We'll go through each of these areas individually. The center of the framework is conversations. Every place we visited said the key is conversations that are informed by measures of how often things are overused, the potential for harm, patient preferences, and patient stories. And the conversations lead to awareness and ownership and then action. But there are 4 things that catalyze those conversations that we're going to talk about in detail. And those are the purple circles at the bottom of this slide. And then there are the external factors that we all acknowledge drive overuse, the financial incentives, and the imperative to do more and not do less. So as one of the people we interviewed said, it's not the data that changes behaviors. It's the conversations that change behaviors in healthcare. Conversations among team members, between providers and clinicians, conversations between clinicians and patients. That's where the action is. And these conversations are about evidence and potential for harm, potential patient stories of harm, how often the service is delivered, and what are patient preferences for their care. These are the conversations that need to happen in every setting in order to address overuse. But there, as I said, there are 4 catalysts that need to be present in order for those conversations to happen. The first is that the organization and leadership has to prioritize this work. There has to be consistent messaging from leadership and from others that this is important work, that we know we're doing too much of things, specific things, and we're going to make protected time and space available for these conversations and facilitate these conversations, and we're going to identify individuals and invite them to participate in these conversations about overuse reduction. Second, it's really critical at these sites that we visited that they commit to maintaining a blame-free environment for the teams to talk about their experiences and exchange ideas. There's no finger-pointing going on here. It's got to be something that people feel psychologically safe to speak up. And you've got to share transparent, meaningful data for these conversations to happen. Third, shared language. You have to get some agreement about what is the language you're going to use to talk about this. In some settings, it's okay to talk about cost and about financial harm to patients, and that's what engages people. In other settings, the mention of cost containment or cost reduction is a non-starter for these conversations to happen. So the organization needs to figure out what is our language internally that we're going to use, and how is this linked to our overall organizational strategic priorities. That's really key in communicating that evidence base then around reducing overuse. And finally, committing resources to measurement. There are not many clinical quality measures currently available that are measures of overuse, and it typically requires that organizations have to commit some additional FTE and time for someone to pull the data and prepare reports on the frequency of overuse services, even down to the individual provider level, and develop a dissemination vehicle for those reports, and then get feedback from care teams and modify the reports in a way that helps them make sense of their data in terms of what's being done. It wasn't too uncommon for us to find that in some places someone developed a passion around an overuse service, and they would stay up nights and weekends pulling the data themselves to generate these reports outside of their usual work hours to begin feeding this information back to their colleagues and their teams. And it was only after they had done that a few times and were starting to show some results that leadership was ready to commit to additional resources to continue the effort of pulling the data and generating these utilization reports. But how do you do this? So this was the next phase. So over the last 2 years, we've partnered with 3 organizations in their efforts to apply the framework to their setting. The UCLA Medical Group in Los Angeles was looking at low-value colorectal cancer screening, too soon, too young, too old, as their mantra went around colorectal cancer screening. The Missouri Primary Care Association was already involved in a chronic pain initiative in their state, but this became an opportunity for them to begin addressing overprescribing of opioids for chronic pain within the federal qualified community health centers that they serve as an organization. And then our own Swedish hospital and health system here in the Puget Sound region of Seattle, where I live, wanted to tackle overuse of the emergency department by patients, and because this was an area that they felt like there was the potential for some harm because of the over-testing and over-treatment that happens to patients in the ED. And they knew that there were some high utilizers of the ED within their patient population that they felt like their primary care providers, staff, and patients could begin addressing in an initiative. So that was their area of focus. We then convened everybody in June of this year after they worked on these initiatives in their own organizations to talk about what are the larger lessons learned from trying to do this work. And I'm just going to share a few of the comments and then share a few of the observations and suggested activities that if you're interested in tackling overuse, you could take on. One of the things that people said throughout the capstone meeting, capstone conference in June of this year is how often the conversation kept coming back to finances and return on investment when what we're really attempting to address is patient safety and preventing harm. And they kept commenting on how interesting it was to focus on patient safety and patient harm because it was not clear where in their organization an initiative like this should land. So reducing overuse wasn't traditional quality improvement for them because for them QI was about addressing care gaps, improving rates of colorectal cancer screening or improving immunization rates, or it wasn't about decreasing the use of services. So it wasn't a traditional QI topic, nor was it purely in the wheelhouse of their patient safety office, which really focused on sentinel events and preventing adverse events, usually in the hospital, and doing root cause analysis and redesigning workflows to prevent adverse events. So this did not feel like patient safety to them. It did not feel like traditional QI to them. They weren't sure where exactly this work in this area should land within their organization. There was also a comment about it's not just about how often patients are harmed. It's about that one person who is harmed and the catastrophic consequences, sometimes catastrophic consequences of that one person. And then we heard, things like, we also heard, of course, low-value care is a problem, but it's just not in our department. We don't have any problem in our area with low-value care. The participants talked about how important it was to connect overuse to harm and safety and how important stories were to doing that in their organization. And they looked for stories about not only just physical harm, but emotional and financial harm done to patients by overuse services. They also said it was important to address moral disengagement from that cascade effect of downstream consequences of overuse of a service. And the example that was given was a preoperative EKG that turned out to be a false positive, that led to a stress test, that led to the cath lab, that led to an inadvertent adverse event from the coronary catheterization that led to a myocardial infarction, all because of a false positive preoperative EKG in a low-risk patient. And they said you have to call out the potential for this cascade effect and point that out to people, because people tend to disengage from this downstream effect. They also commented about how important it was to have de-identified data to talk about overuse with specific names attached to it. Dr. Smith's MRI for chronic low back pain rate per 1,000 is 16. Dr. Jones's MRI for chronic low back pain rate per 1,000 is 54. They said these are necessary but difficult conversations to have within the medical group. And it's important that you have these conversations in places where it's safe for providers to have these conversations about why you see such variation occur. It was also a challenge for them to develop locally valid, clinically meaningful measures that it required significant clinician input because there were some measures that there was a question about, well, at what level is this appropriate versus inappropriate use? And it required clinician input on that. They also said it was really important to balance overuse with underuse, so that you could see that things were getting better in areas where there was underuse as you were addressing the overuse, the balance issue. And then respecting the workflow and autonomy. We're all familiar with the issue of burnout in care, and making the right thing to do the easy thing to do, and addressing how do we make workflows and give people autonomy in the moment in the clinic, while at the same time addressing these overuse services. So a couple of specific strategies that the sites employed. They brought patients into the conversation, patient representatives, ones that sometimes had been harmed, or where there was a near miss from an overuse. They talked about starting off with areas of overuse where you know the rate is very high. It's more difficult to tackle overuse in areas where the rate is very low. So start with areas where the overuse rate is very high, and there tends to be a broader consensus about, well, maybe our overuse rate in this area is too high. Maybe we should do something about it, so that you get some early success under your belt to develop some momentum. They talked about how important it was to provide clinicians and patients with alternatives, even if the alternative was just a conversation, and some patient support and some patient self-management, and some patient education. Because relinquishing something without replacing it is very, very difficult. So they often provided scripts for conversations. So providers would have examples of scripts they could use. Oftentimes the conversations about the variation between providers in rates of use actually end up turning into conversations around, well, what do you say to your patient when they ask you for another follow-up MRI 6 months later when you know it's not indicated? How do you explain that to them? And so providers were sharing ideas around how to talk to patients. They talked about how they created time and space for these conversations. The staff newsletter had an overuse corner to celebrate successes in this area. On the monthly medical staff meeting, it was a standing agenda item to talk about the whatever overuse reduction initiative they were working on currently, and gave updates on it. Some of the hospitals were having their monthly morbidity and mortality case conference. About every third or fourth one was about a choosing wisely topic, where they presented a patient case, and then they gave monthly reports on rates of overuse, so the audit and feedback, and gave some trends and provided a target goal that everybody could agree to. So we're going to turn now and pivot to this use case, where we're going to need your involvement. So if you're still with me after that long narrative over the last 25 minutes, get your coffee heated, and take a deep breath, stand up and stretch. We're about to get involved in an activity here. So this was a use case that was presented at our capstone meeting in June. It's an example of an overuse area, and we use this use case to help develop some ideas around specific strategies for tackling overuse. And we're going to ask you to help us think through this. And there's going to be a poll question in a few minutes. I'm going to hand the control back over to Kelly to do that. But let me read the use case to you. So a prime example of overtreatment is using glucose-lowering medications to achieve what we call hemoglobin A1Cs, which is a measure of blood glucose control, less than 7 among older patients with type 2 diabetes, for whom such tight control has few benefits and, in fact, can lead to serious harms such as hypoglycemic episodes that lead to confusion and falls. And it's not and it's not just that these are one-time events. Sometimes these can cause permanent harm, irreversible harm, if the hypoglycemic episode is severe enough. So despite efforts to raise awareness of this, nearly 1 in 5 older adults are overtreated, and very few of these patients have their medications de-intensified. In fact, there was a recent study about this in which they identified older adults with a hypoglycemic episode, well documented, on these oral hypoglycemic medications, and less than 20% of them had their medications de-intensified or lowered dose or stopped after these hypoglycemic episodes. Very rarely was there a change in this, even after an episode, a hypoglycemic episode. So if you're in your clinic, your hospital, your health system, and your goal in your health system is to reduce the use of insulin and oral hypoglycemic medications among older patients with an A1C, and you want to start an initiative in your setting to address this overuse phenomenon, we want your input on this. We want to know where you would start. So what key change would you recommend first in your organization to address overuse of hypoglycemic and insulin? So A, use best practices in communication to support conversations and learning among clinicians and care teams. Or B, highlight the potential for patient harm as part of those conversations. Or C, ensure actionable utilization of data that's readily available to support these conversations. Or D, provide resources to support these conversations about overuse with patients and families. So I think the poll is open. Oh, look, it's open. So which one of these would you choose first?
And just a technical point, again, click the box, not the text. I also want to let everybody know that I unmuted everyone's line, so you are welcome to ask questions verbally as well as while we're doing this poll. But if you do have a lot of outside noise, please mute yourself.
So is it questions like who's going to win the National College Football Championship game this year, or? The winning lottery number this weekend. Oh, I haven't answered the poll yet. Should I answer the poll?
You should answer the poll.
All right.
Okay. We've had it open for a couple of minutes, so after you say you've finished,
Does anyone have questions about the presentation itself? I mean, I can't believe there aren't people out there who don't have any questions about what we've learned about engaging clinicians and patients around overuse. Got to be something you struggle with. Or maybe everybody's figured it out. I don't know.
So about 70% of the people have answered the poll. Do you want me to close it so we can see the results?
Yeah, let's close it and see what we got.
Okay. It looks pretty close. but it does seem like using actionable data was the winner. So I will open the next poll. All right. The next poll is open. And again, remember, click the box, not the text.
But is this the same question?
It should be what activity would you recommend under the data?
Ah, I see. Okay, never mind. I see what you're doing. Ah, okay. So under data, what activity would you recommend to promote the change? A, B, or C? I think it's interesting that people are choosing data first, because that's actually what each of our partnership sites decided to do first and what took them the longest. It was really a struggle for them to get reliable, actionable data out of their systems to take to their providers and their teams. It always took them twice as long as what they estimated.
And I'll say for the folks who might have clicked the text instead of the box, and you ended up getting no answer, if you want to put your answer in the chat box, that's still good. And we have about 15 people who haven't answered, and we have a little bit of a tie. It's close, but a few more would break that tie.
Let me ask,
and Michael,
anyone...
don't forget to answer yourself.
I think I did. I think I
okay.
did. Yeah. I think I did. And I just want to ask, has anyone had these kind of conversations around their data in use in their setting for an area like choosing wisely topic? And what's been your experience?
This is Daniel Lum. I'm from Lurie Children's Clinically Integrated Network. We actually send out a report about ED utilization quarterly to our membership, and we talk specifically about the kind of ambulatory sensitive ED visits and kind of where they stand with that. And we've actually had very good conversations among our providers as to what they might be able to do differently to try and, kind of bring down ED utilization.
And what kind of follow-up do you have to the conversation? I mean, I'm sure there's some really good ideas that surface during the conversation. What do you do to follow up the initial discussion?
We certainly bring back some of the discussions that the folks that go out into the field have, and bring it back to our leadership, and then kind of talk about, well, what else can we do as far as promoting kind of some of those good ideas that have come out of those discussions.
That's great. That's great. Yeah, I think that's a great area to explore these ambulatory care sensitive conditions and what primary care can do. You talk about the variation in those ED admissions across locations, or how do you do that?
We talk about variation across the network, so the individual practice can see their rate relative to the rest of the practices in the network, and so they can look at the data that way and see how how they compare to other practices in the area. So we blind the other practices, but we show them their data and compare it to everybody else in the network, but they don't know who everybody else is.
Right. That's good.
Someday we'll actually unblind all the data and everybody will see everybody's score, but we're not there yet.
Takes some relationship building to do that, yeah, and trust. Well, it looks like people really want to empower clinicians. So I guess the question is, how do you do that? How do you empower clinicians to act on the variation data? What are some strategies people have used?
Hi, this is Victoria Valencia. I work at Dell Medical School at UT Austin. But I have an example I'd like to share about that when I previously worked at UCSF. So we had a team-based dashboard there that provided metrics around discharges mostly, but also around somewhat of high-value care and overuse. We had some information on there, for example, on the number of sticks that people receive to draw blood while they're in the hospital. And that was one of our patient-centered metrics of overuse. We really focused that on the patient rather than the number of tests or CBCs or BNPs. We focused on the number of times the patient actually got stuck for blood. And that dashboard, the way we got more engagement, I think, is that we provided structured time after an existing meeting that the teams had every Wednesday after they did a case review like NNM or some other standing meeting they had at that time. We went back and did what we call data rounds, and they came into the room with us. We went over their dashboard and their metrics. We talked about issues that they might have with the data. Did they have any questions? And I also learned from that process where we adjusted metrics and we changed how we collected the data in some cases and added annotations to help explain things that might have been unclear. So I think providing a structured time to review the data was really helpful, because otherwise the teams just didn't have the time in their busy day rounding off patients to sit down and really digest what was there.
And if you don't mind me asking, how much time did you take to do that?
So we did that once a week, and we probably only took about 15 or 20 minutes after that 1 hour before they left and went back to write orders and things like that for the rest of the day. Yeah.
Yeah. It doesn't. I think our observation is in the same. It doesn't take a long amount of time. 15 to 20 minutes is often all it takes to get the conversation started. Did you ever hear any follow up about whether the conversation continued later?
So I think mostly they took place in that structured time.
Yeah.
What I did hear from the teams was that they would go back and follow up on the dashboard like the next day to see if their numbers changed, because it updated every day with discharges from the previous day. So sometimes that kind of spurred them to go back and kind of check it more often. How sustainable that is, I'm not sure.
Yeah.
But I think, like you've said throughout, just having that conversation and starting the conversation and giving structured time to do that was really helpful for us.
Oh, that's brilliant. Yeah, that's brilliant. Because we sometimes heard that just having the conversation once would lead to subsequent hallway conversation. And like you said, maybe they're checking the dashboard the next day as a team just to look and see how they're doing if you've got real-time data. That's awesome. Yeah. So going back to the hypoglycemic use case, can you give a concrete example of what you would do if you were focused on de-intensifying meds for diabetes in older patients? What's the first step you would take in your setting to get things started? How would you start?
You can also use the chat box to chat to everyone if you'd like you to put your answer in the chat box as opposed to speaking, but we would love to hear from you too.
I mean, other than lecturing primary care doctors about how horrible they are and they're killing their patients, what else would you do? I'm just kidding.
So, Michael, I have a question.
Sure.
I know this example came from a specific place, and I'm wondering with any of the ones that you did work with, especially with the concerns raised with sort of the balancing measures and overuse versus underuse, did any of those projects, while they were working on it, measure both of them and share the information, share the data on both levers to their docs?
Yeah, that's a really good question. So I know for the colorectal cancer screening work that was done, yes, they were sharing both appropriate colorectal cancer screening rates and complementing it with overuse rates. What's interesting about their findings is when they looked across all their clinic locations, there were some clinics that were doing really well on, say, their HEDIS measure for colorectal cancer screening. But they also tended to be the same sites that had the highest rates of overscreening, too young, too often, too old as well. So it was important for them to see you may be overshooting the mark in colorectal cancer screening within your patient population, which was an interesting conversation to have with those clinics, because you certainly did not want them to fall back and not be meeting their target for what they wanted them to do in terms of screening for colorectal cancer. But yeah, they shared some balancing measures such as that. The ED work, they looked at both ambulatory care sensitive conditions and other overuse of the ED, as well as appropriate use of the ED, and how to help patients know when to appropriately use the ED versus when one of their urgent care clinics would be an appropriate location. So they looked at more measures of appropriate use as well to see what the distribution of when can something be done in primary care versus when is it appropriate to go to urgent care versus when is it appropriate to go to the ED, and develop some measures of all three.
Great. And while we were discussing this, the chat box sort of lit up. So I have some comments and questions I can read to you. Right. Linda Whitco suggested that one of the ways that you could implement this in a setting is to provide options for providers to offer to older patients other than strict control.
Right.
We also have a question from Anikia Nelson that asks, do you have any thoughts on how payers can engage providers on decreasing overuse?
I think the answer is yes and no. I think it's very useful because payers have better information, oftentimes in their claims data about rates of overuse, that they could provide some feedback to providers about within their patient population, how well are they doing around rates of overuse. I would say one of the most interesting and informative things that's been done in our state and some other states is for the payers to get together and contribute data to the Washington Health Alliance, where they ran their data through the Millman Waste Calculator and identified where are their highest rates of overuse occurring, where is the low value care happening. And so for payers to contribute collectively to that effort, it then allows people like the Washington Health Alliance and others to begin develop some ideas for some initiatives that could be rolled out across the state, across medical groups as well. So it's a collaborative effort, and everybody benefits from that. Patients, payers, providers, everybody.
We also have a few more comments and questions. Again, this is answering, I think, the question that we have on the slide. Ask the physician open-ended questions. What is your reaction to this article? Do you see yourself implementing this in your practice? How would you go about explaining this to your patient? And what would prevent you from implementing this in your practice as a way to engage physicians?
Yeah.
There's a follow-up from the same gentleman that says, payers rely on health systems to influence and affect physician performance, and academic detailing is a tool we use at Northwestern Medicine. I would also just say that from the grants that we did, one of the things that sort of bubbled to the top when talking about clinician education, which was a really important aspect of engaging providers, was that it either happened in a very small group or as academic detailing. So I think that's a good lesson or example.
Yes. Yeah. If you do it with academic detailing or a small group, you're more likely to have a conversation and talk about it in terms of the clinician education piece, and ask some of the questions that were asked just a minute ago about this. I would say the other thing that payers could do is distribute some tools and resources to providers about how to have these conversations with patients. What are some scripts you can use? We all, as clinicians, have scripts we use when we talk to patients about certain topics or certain conditions, and we could talk to patients about the risk versus the harm of doing something. But I think couching it in terms of harm or potential harm is a really powerful motivator. And the second thing I'll say is, in addition to data, it really helps to have a patient story about overuse. In one of the exemplar sites that we visited, the CFO's wife had an adverse event in the hospital from an overuse service. And he went around his academic setting to every single department in the School of Medicine and told his wife's story to every specialty group in the academic health center about the potential harm from overuse services. So stories are an emotional hook that data don't provide.
We have another comment in the chat box, and it says fostering healthy competition within the group practice is an effective tool. Who will have the highest scores? Physicians tend to be very competitive.
That is so true. Yeah.
And I can say one of the things that we've seen in Choosing Wisely implementation, not just the competitiveness of looking at rates across physicians, but of a way to get Choosing Wisely to, or working on overuse to work at a health system that hasn't started it. We've seen a number of people do innovation contests. So they have contests between their clinicians that say, if you come up with a good idea, we'll provide you with, a small seed amount of money to start it. And that's the way that Choosing Wisely has started in quite a few organizations.
And can I just add before I forget,
Sure.
And I can't believe I didn't do this on one of these slides, but if you just go to takingactiononoveruse.org, the website, so it's just the name, takingactiononoveruse.org, you'll find a lot of tools and resources there that we've developed over the last 3 years, including an organizational self-assessment about readiness to tackle overuse, a change package that includes some implementation guides, some of the things that have been in the slides here around suggested key activities that you could do under these different change concepts, shared language, developing a culture of trust and innovation, prioritizing the work that we've harvested that might be useful to people to look at the change package and the implementation guide at the website, takingactiononoveruse.org.
And for everyone listening, I have been peppering that website throughout the chat box throughout this conversation. So if you didn't get it, you can click on it from the chat box, probably anywhere you are on the chat box.
Thank you, Kelly.
No problem. We also have another chat from the chat box, and we have Mark Gregg, who says, we included choosing wisely as a clinical integration pay-for-performance measure beginning in 2017.
Cool. That's great. How do we find out more about it? Where do we go to find out more about it?
Feel free to put it in the chat or speak aloud. And that gives me a good question for you, Michael. How do you feel, is there a difference, do you think, between financial incentives and intrinsic incentives? Do you think it needs to be a combination? What are your thoughts on that?
Yeah, so my thought on that is that financial incentives are an important issue for us to consider in this, but they're not directly addressable by organizations. We all often live in a fee-for-service environment where volume is rewarded over value, and there's some perverse financial incentives in the way healthcare is reimbursed. We all know that. But the financial incentives don't drive the conversation I have with the patient about ordering a test necessarily, except for the fact that I could be influenced by my peers and what they do in ordering that test or treatment. If my peers are doing it, I'm more likely to do it. And if my peers are more likely to do it, maybe they're more likely to do it because the organization we're in has done some what we call behavioral nudges and encouraged us to do it because of the financial incentives that exist to do that. But we know from behavioral economics that direct financial incentives to change provider behavior are not as effective as in using intrinsic motivators, appeals to professionalism. For example, that's what the talking about patient harm is about. It's appealing to that intrinsic motivator of us as professionals to do no harm. It also means that doing this work is qualitatively different than doing traditional improvement work. Someone at the meeting said, this feels like that TV show Stranger Things, where you've just fallen through the wall into an alternate universe of trying to do this work. And it's true, because it involves me as a provider addressing that I may have been doing something, an overuse service that may have harmed one of my patients. That's an emotional issue for me. And I've got to grapple with that as well. If I'm going to stop doing something, that means that I have recognized that what I'm doing may be harming people. And that's sometimes a difficult thing to swallow for providers, and difficult to let go of that mental model or that belief system that says I would never do anything to harm somebody.
I very much agree with you. Do we have any final questions or comments? I will tell you that we did hear from Mark Gregg that he's working on a publication, so hopefully we'll hear more about how they've included choosing wisely as a clinical integration measure. We also have from Danielle Lom, read Daniel Pink's book, Drive, Financial Incentives, Motivate, Focus You Narrowly, Intrinsic Motivators, give you purpose, autonomy, mastery, and will focus you more broadly.
I love that book.
And we also have one unrelated question for Michael, if there's time, that one of our participants is going to Seattle tomorrow and wants to know how bad the smoke is.
The smoke is supposed to clear by tomorrow afternoon, thank God.
All right. So we have, and one other person offering a book suggestion is also a reading nudge. But since we're at 4:57, Michael, do you have any final comments you want to give to the participants?
Just visit our website, takingactiononoveruse.org.
Great. Thank you so much today for speaking. And thank you, everyone, for joining us. We will be sharing this recording on Workplace. You can also email if you'd like to receive a link or a copy of the recording. And again, if you want to know more about the framework, we'll post the website also on Workplace, so you can go to it directly if you didn't get it in the chat box. And we will hopefully see all of you next month. Thanks so much for joining us and having a great conversation today.
Thanks, everybody.
Thanks.